Hello and welcome to Patient Power. I'm Andrew Shore. At the 2014 meeting of the American Society of Hematology in San Francisco, we had the chance to sit down with noted CLL experts, among them Dr. George Fallows from Cambridge in the United Kingdom. And he spoke to us about the changing landscape of CLL and the chance for a non-chemotherapy approach and his views about that and how patients can get, if you will, personalized medicine. Here's Dr. Fallows.
Well, I think the message for patients back home in the UK is development continues at great pace. There are new pathways, new inhibitors, new antibodies. The scope for development is huge. And I think the trials that are going to be coming, and also coming to the UK, are really going to be exciting in terms of taking us forward. All of the non-chemotherapy drugs come with certain limitations, the limitations primarily being cost and trying to get the regulatory authorities to see their need, see the need and requirement for these in our practice. We have various meetings. We've got the Cancer Drugs Fund that's sitting before Christmas, and then these drugs will be going before NICE. I think those of us, the clinicians managing CLL practices and our patients, appreciate the data, and we're all pushing to try and get access to these drugs in the clinic in the NHS. Do you benefit from chemotherapy for a short period and then a remission and then use one of the new drugs when your disease wakes up again? Or conversely, would you benefit from going straight on one of the new drugs and actually saving yourself the potential toxicity? Now, the new drugs are tremendously appealing in terms of perhaps mechanism of action, the toxicities, tablets rather than infusions, but we don't actually know. We don't know that the continual daily dosing that they require, we don't know whether that's going to cause problems in the long term. Will it encourage resistance? And actually, will the patients benefit from that early on in their treatment? And without the trials, and we in the UK are running those trials, without those, we're not going to know. Patients vary enormously. You have patients who are genuinely keen to travel for clinical trials, and in my practice, if I don't have a trial open but I have a colleague in a city, very open discussions. I've moved people all the way down to Plymouth from Cambridge for clinical trials before. So I think access is key. You're absolutely right. We in the UK at the moment have been a little restricted in terms of getting hold of the drugs. But then in all fairness, the European license for the two front-running new drugs, ibrutinib and Idela, these licenses have only just come through in the last few months. As a CLL doctor, of course I empathise with watch and wait. You hear all of these things thrown around, watch and worry, and it must be really difficult for people. They hear all the news all the time that in the UK our cancer outcomes aren't quite as good because we're slow to get going, and then you come up to clinic, you sit with someone like me and says, oh look, basically we're not going to do very much. And of course that's challenging, but there's good data at the genetic level that perhaps chemotherapy can stir things up. Perhaps early use of chemo can actually bring forward resistant clones. And I really do think at the moment, and this is supported by data, that you should not be having chemotherapy if your disease is stable and you are well. Now, of course, with the new drugs will that change? But again, this really will require proper trials, because if you are stable and relatively well with your CLL, exposing yourself to daily levels of drug that can induce resistance, doing that early on, it might not be the right thing to do. So again, while the natural inclination is to think, brilliant new therapy, toxicity is pretty good, let's get going on it. This does have to be worked through quite carefully. Precision medicine and this tailored individualized therapy is a dream of cancer medicine. I think CLL in some ways, if you look at the story with the 17p deleted, these are the patients with particularly difficult CLL, we've led the way by, for the last 5-10 years or so, directing people towards specific therapies for these leukemias. But that's of course a very broad overview statement. It's very clear looking at the genetics, well really across all cancers, but CLL, we're getting a feel already that some genetic subtypes benefit disproportionately from one type of treatment. Other types with mutations of specific genes, and I mean by that notch, well, maybe they don't benefit from antibody therapy. So as the information comes through from the labs into the clinic and then into via the clinical trials, we're going to get a better picture. And I think you're right. I think the future, truly individualizing how we approach our patients will come, but it's not going to be 2015.
Remember, we have many other interviews with CLL experts to give you the whole perspective of where we are now as treatment for CLL changes. I'm Andrew Shore. Remember, knowledge can be the best medicine of all.